Let's now get to the heart of the matter and look at the specific concepts which seem to confuse many people. With a proper understanding of these, we will not be in a moral dilemma anymore. Pro-life is the belief that all human life is created equal, regardless of size, level of development, environment, and degree of dependency. Therefore, taking the life of a preborn baby is a violation of the fundamental right to life. Pro-choice is the belief that every woman should be endowed with a right to her own life and body. Therefore, denying a woman an abortion is denying her the right to bodily autonomy. Clearly, the choice of the unborn is not considered at all. Again, I want to ask you to ensure that your children are not present for the following information, where we will look at abortion in some more detail. We need to distinguish between abortion on the one hand and the legitimate therapeutic medical treatment to save a mother's life on the other. Abortion is the deliberate, direct and intentional action of killing the unborn at any stage of embryonic development after fertilization. It is a direct attack on the preborn baby with the sole intention of killing it. It is murder, and murder with the intent carries serious weight in medicine, in criminal law, and particularly under God's moral law. The most common reasons for abortion are the following: inconvenience, also referred to as elective abortions. It is the purposeful killing of a preborn baby to terminate an unwanted pregnancy because of one or more of the following factors that potential parents feel might disrupt their lives. The timing is wrong. They cannot financially provide for the baby. The social and emotional impact, for example, the shame associated with unplanned pregnancies. Most abortions in the US are performed for these inconveniences. An extremely low number, less than 0.5% of abortions are performed because the baby was conceived from rape. Johnson's 2016 research quoted in Dawson's paper reports 0.3% in the US and Europe. And he also states that abortions performed for incest are extremely rare, constituting only 0.03% of all abortions in the US. Now let's just stop for a moment. Living with the impact of a violent rape is not something I wish to diminish in any way whatsoever. This must be one of the most horrific, difficult, and life-altering things that a person can go through in their lifetime. But even though the rapist committed a horrible crime, and the rape may result in pregnancy, the rapist, the father of the baby, is the aggressor. But the unborn baby is just as much an innocent victim as the mother. So we have to ask the question, should the baby then be punished, killed for the crime of the father? Let's see what the Bible says. The soul who sins shall die. The son shall not bear the guilt of the father, nor the father bear the guilt of the son. The righteousness of the righteous shall be upon himself, and the wickedness of the wicked shall be upon himself. Even though this will be an incredibly difficult time for the mother, hardship does not make killing an innocent baby morally acceptable. Rape is a heinous evil, but so is murder. Two wrongs don't make a right. The baby has a right to live. If you found out today that you were the result of your biological father raping your mother, would you feel that you no longer had the right to live? The baby's humanness is in no way dependent upon the circumstances in which the baby was conceived. The baby is always a human being made in the image and likeness of God. Victims of rape need love, support, and compassion, and it's worth remembering that God can bring something good out of anything, even out of something so life-altering as being raped. For example, Rebecca Kisling was conceived out of a brutal rape at knife point by a serial rapist. She's been an international pro-life and adoption speaker since 1995. Politically influential, she changed the hearts of many politicians and legislators across the US, Canada, and Europe. She's helped pregnant rape victims all around the world to choose life for their children. I want to encourage you to visit her website to read her testimony. And then there is the horrific occurrence of sex-selective abortions. You wanted a boy, now it's a girl, so let's just kill her. The eugenic idea of aborting babies with disabilities or defects teaches that it is acceptable, even right, to abort children for birth defects such as sickle cell anemia, Down syndrome, blindness, spina bifida, although many with such conditions live worthwhile lives. A significantly high number, 90%, some say, of babies diagnosed with Down syndrome are aborted because of their disability. Interestingly, eugenics, which is the attempt to breed a better human race by applying evolutionary principles, was started by Francis Galton, the cousin of Charles Darwin. Of course, if you view humans as nothing more but evolved animals, you would probably have no problem with a sick idea. Ironically, making life easier and more accessible to people with disabilities are at the order of the day in modern society, but we don't think twice about killing them in the womb. Therefore, even if a fetus may have severe physical and mental abnormalities or conceived as a result of incest or rape, it does not in any way make him or her less human. However, if the unborn from the point of conception is fully human, which I believe it is, then it follows that abortion, regardless of the cause of pregnancy reason, has moral and ethical culpability. Now, this information is most important because the concept of woman's health as a reason for abortion is by far the most obvious and consistent loophole historically and currently used to justify and legalize the killing of babies through abortion on demand. This is because in Doe versus Bolton, the United States Supreme Court case, along with Roe versus Wade legalized abortion in 1973, the court announced that health for the purpose of late-term abortion law would be synonymous with the mother's physical, emotional, psychological, in other words, mental, familial, social well-being. A very broad spectrum indeed. In other words, this allows abortion for virtually any or no reason at all, under the guise of health of the mother. Social well-being in particular is a completely subjective phrase. Let's be clear. The humanness and moral value of the baby is inherent and in no way dependent upon the health of the mother, be it physical or emotional, her social well-being or the welfare of the mother. Health of the mother should really be life of the mother, since the term health of the mother provides an incredibly broad interpretation where almost any reason during pregnancy can be used to justify an abortion. Johnston's 2016 research reports that only 0.1% of abortions in the US are performed with a stated reason of saving the life of the mother. So the sum of all abortions when considering rape, incest, and the life of the mother collectively constitute less than 1% of all abortions. Yet these extreme and rare examples are used to justify abortion in general. But the truth is, and this is also very, very important, there is absolutely no instance in which abortion is the best treatment to preserve a woman's health, physically or mentally, nor to preserve her life. In fact, abortion at all stages of pregnancy is dangerous for a woman's physical and mental health. Dr. Bernard Nathanson from the American Bioethics Advisory Commission stated that There are no conceivable clinical situations today where abortion is necessary to save the life of the mother. In fact, if her health is threatened and an abortion is performed, the abortion increases risks the mother will incur regarding her health. There is only one purpose for abortion: ending the life of the child. The health of the mother situation for abortion is simply bogus. We'll learn more about this throughout this presentation. Now, the following 2 videos contain some shocking information demonstrating that abortion is a violent, murderous act. So please ensure that your children don't see this. I don't usually do presentations on such upsetting subjects, but before we just decide to support something, we better make very sure what it is that we are supporting. Dr. Levatino is a former abortionist who personally performed more than 1,200 abortions. Today, he is pro-life. By the way, he also plays the role of an abortionist in the powerful film Unplanned. In this powerful, much discussed 5-minute video by Living Waters, Dr. Levatino testified in detail in court about one of the procedures used in a midterm abortion. Please notice the reaction in the audience.
This investigation of Planned Parenthood is based on false premises, one after another after another. It's time to stop wasting time, get on with meaningful work, and stop picking on women and trying to take their choice away. I yield back the balance of my time.
The time of the gentleman has expired. We welcome our distinguished witnesses today. Do you and each of you swear that the testimony that you are about to give shall be the truth, the whole truth, and nothing but the truth, so help you God? And I'll now begin by introducing today's witnesses. The first witness is Dr. Anthony Levatino. Dr. Levatino is a board-certified obstetrician gynecologist. Over the course of his career, Dr. Levatino has practiced obstetrics and gynecology in both private and university settings, including as an associate professor of OB/GYN at the Albany Medical College. And Dr. Levatino, we'll begin with you. Welcome.
Thank you, Chairman and members of the committee. I only have 5 minutes, so I'm going to get right to it. Second trimester D&E abortions performed between roughly 14 and 24 weeks of gestation. Your patient today is 17 years old. She's 22 weeks pregnant. Her baby is the length of your hand plus a couple of inches. And she's been feeling her baby kick for the last several weeks, but she's asleep on an operating room table. You walk into that operating room scrubbed and gowned, and after removing laminaria, you introduce a suction catheter into the uterus. This is a 14 French suction catheter. If she were 12 weeks pregnant or less, basically the width of your hand or smaller, you could basically do the entire procedure with this. But babies this big don't fit through catheters this size. After suctioning the amniotic fluid out from around the baby, you introduce an instrument called a Sofer clamp. It's about 13 inches long. It's made of stainless steel. The business end of this clamp is about 2.5 inches long and 1/2 inch wide. There are rows of sharp teeth. This is a grasping instrument. When it gets a hold of something, it does not let go. A D&E procedure is a blind abortion, so picture yourself introducing this and grabbing anything you can blindly and pull, and I do mean hard, and out pops a leg about that big, which you put down on the table next to you. Reach in again, pull out an arm about the same length, which you put down on the table next to you. And use this instrument again and again to tear out the spine, the intestines, the heart and lungs. Head on the baby that size is about the size of a large plum. Can't see it, but you pretty good idea you've got it if you've got your instrument around something and your fingers are spread about as far as they go. You know you did it right if you crush down on the instrument and white material runs out of the cervix. That was the baby's brains. Then you could pull out skull pieces. And you have a day like I had a lot of times, sometimes the little face comes back and stares back at you. Congratulations, you just successfully performed a second trimester D&E abortion. You just affirmed her right to choose.
One more question, Dr. Levatino. Why did you end your practice of doing abortions?
I did over 1,200 abortions over a 4-year period in private practice, not counting the ones that I did during my training. I met my wife during my first year of training at Albany Medical Center. We got married about a year later and found that we had an infertility problem. After years of failed infertility treatment and several years trying to adopt a child, we were blessed with adopting a little girl that we named Heather in August of 1978. As sometimes happens in those situations, my wife got pregnant the very next month, and we had 2 children 10 months apart. 2 months short of my daughter Heather's 6th birthday, she was killed in an auto accident and literally died in her arms in the back of an ambulance. Anyone who has children might think they have some idea of what that feels like, but unless you've been through it yourself, you have no idea whatsoever. I know people find it hard to believe, but what do you do after disaster? You bury your child and then you go back to your life. And I don't remember exactly how long it was after my daughter died that I showed up at Albany Medical Center OR number 9 to perform my first second trimester D&E abortion. I wasn't thinking of it as anything special. This was routine to me. But I reached in, literally pulled out an arm or leg and got sick. You know, earlier on I described stacking up body parts on the side of the table. It's not to, gross people out, to use a simple term. When you do an abortion, you need to keep inventory. You have to make sure you get 2 arms and 2 legs and all the pieces. If you don't, your patient's going to come back infected, bleeding, or dead. So I soldiered on and finished that abortion. And I know it sounds, as I said, hard for people to believe, but I'm telling you straight up my experience. You know, after over 1,200 abortions, first and second trimester up to 24 weeks and all the rest of it, and being very dedicated to it, for the first time in my life, I really looked at that pile of body parts on the side of the table. And I didn't see her wonderful right to choose, and I didn't see all the money I just made. All I could see was somebody's son or daughter. And I stopped doing late-term abortions after that, and several months later stopped doing all abortions.
Thank you.
In this video by Live Action, Dr. Livatino explains abortion procedures in the first, second, and third trimesters, and this includes the risks and adverse effects to the mother. Bear with me, since we can only stand for the truth if we truly understand what it entails.
My name is Dr. Anthony Livatino. I'm a practicing obstetrician gynecologist, and I performed over 1,200 abortions. First, I'm going to describe a first trimester medical abortion. This is a procedure in which the mother swallows pills in order to terminate her baby, and it is performed up to the 9th week of pregnancy. The procedure involves 2 steps. Step 1. At the abortion clinic or doctor's office, the woman takes pills which contain mifepristone, also called RU46. RU46 blocks the action of a hormone called progesterone. Progesterone is naturally produced in the mother's body to stabilize the lining of the uterus. When RU46 blocks progesterone, the lining of the mother's uterus breaks down, cutting off blood and nourishment to the baby, who then dies inside the mother's womb. It is important to note that even after it has been taken, it is possible to reverse the effects of RU46 and save the baby if progesterone is administered. The sooner, the better. Step 2. 24 to 48 hours after taking RU46, the woman takes misoprostol, also called Cytotec, that is administered either orally or vaginally. RU46 and misoprostol together cause severe cramping, contractions, and often heavy bleeding to force the dead baby out of the woman's uterus. The process can be very intense and painful, and the bleeding and contractions can last from a few hours to several days. While she could lose her baby anytime and anywhere during this process, the woman will often sit on a toilet as she prepares to expel the child, which she will then flush. She may even see her dead baby within the pregnancy sac. At 9 weeks, for example, the baby will be almost an inch long, and if she looks carefully, she might be able to count the fingers and toes. After she has disposed of her baby, the woman may have bleeding and spotting for several weeks. Bleeding lasts, on average, 9 to 16 days. 8% of women bleed more than 30 days, and 1% require hospitalization because of heavy bleeding. RU46 is only FDA approved for the first 7 weeks of pregnancy. While RU46 can be used off-label up to 9 weeks, the failure rate increases as the pregnancy progresses. At 7 weeks, it has a 5% failure rate. At 8 weeks, an 8% failure rate, and at 9 weeks, a 10% failure rate. If failure occurs, she will usually be offered a surgical abortion. For the mother, medical abortion often causes abdominal pain, nausea, vomiting, diarrhea, headache, and heavy bleeding. Maternal deaths have occurred, most frequently due to infection and undiagnosed ectopic pregnancy. First trimester surgical abortion called suction D&C, dilatation and curettage. This is the most frequently performed abortion and is used typically from 5 to 13 weeks of pregnancy. After administering anesthesia, the abortionist uses a speculum like this. This is placed inside the vagina and opened using this screw on the side, allowing the abortionist to see the cervix, the entrance to the uterus. The cervix acts as a gate that stays closed for the duration of pregnancy, protecting the baby until it is ready for birth. The abortionist uses a series of metal rods called dilators, like these, which increase in thickness, and inserts them into the cervix to dilate it, gaining access to the inside of the uterus where the baby resides. The baby has a heartbeat, fingers, toes, arms, and legs, but its bones are still weak and fragile. The abortionist takes a suction catheter like this one. This is a 14 French suction catheter. It's clear plastic, about 9 inches long, and it has a hole through the center. It is inserted through the cervix into the uterus. The suction machine is then turned on with a force 10 to 20 times more powerful than your household vacuum cleaner. The baby is rapidly torn apart by the force of the suction and squeezed through this tubing down into the suction machine, followed by the placenta. Though the uterus is mostly emptied at this point, one of the risks of a suction D&C is incomplete abortion. Essentially, pieces of the baby or placenta left behind. This can lead to infection or bleeding. In an attempt to prevent this, the abortionist uses a curette to scrape a lining of the uterus. A curette is basically a long-handled curved blade. Once the uterus is empty, the speculum is removed and the abortion is complete. The risks of suction D&C include perforation or laceration of the uterus or cervix, potentially damaging intestine, bladder, and nearby blood vessels, hemorrhage, infection, and in rare instances, even death. Future pregnancies are also at a greater risk for loss or premature delivery due to abortion-related trauma and injury to the cervix. Second trimester surgical abortion called dilatation and evacuation, or D&E. A D&E is performed between 13 and 24 weeks of pregnancy. After administering anesthesia, the abortionist uses a weighted speculum, like this one, that opens the vagina widely. Because second trimester babies are so large, this greater access facilitates a late-term abortion. Late-term abortion requires that the cervix be prepared 24 to 48 hours in advance with laminaria. Laminaria is a type of sterilized seaweed that absorbs water over 8 to 12 hours and swells to several times its original diameter. Once removed, metal dilators can be used to further open the cervix as needed. Once the cervix has been stretched open, the suction tube is placed inside. A baby at 20 weeks gestation is as big as the length of my hand, from head to rump, not counting the legs. The suction machine is turned on, and pale yellow amniotic fluid surrounding the baby is suctioned out through the catheters. With babies this big, they don't fit through catheters this size. The baby's bones and skull are too strong to be torn apart by suction alone. This is a Sofer clamp. A Sofer clamp is made of stainless steel. It's about 13 inches long. The business end is about 2.5 inches long and a 1/2 inch wide, and there are rows of sharp teeth. This is a grasping instrument. When it gets a hold of something, it does not let go. The abortionist uses this clamp to grasp an arm or leg. Once he has a firm grip, the abortionist pulls hard in order to tear the limb from the baby's body. One by one, the rest of the limbs are removed, along with the intestines, the spine, and the heart and lungs. Usually the most difficult part of the procedure is extracting the baby's head, which is about the size of a large plum at 20 weeks. The head is grasped and crushed. The abortionist knows he has crushed the skull when a white substance comes out of the cervix. This was the baby's brains. The abortionist then removes skull pieces. He removes the placenta and any leftover parts of the baby with a curette, scraping the lining of the uterus for any remaining tissue. The abortionist then collects the baby parts and reassembles them to make sure that there are 2 arms, 2 legs, and all the pieces. Once all the parts have been accounted for, the abortion is complete. For the woman, this procedure carries a significant risk of major complications, including perforation or laceration of the uterus or cervix, with possible damage to the bowel, bladder, and other maternal organs. Infection and hemorrhage can also occur, which can even lead to death. Future pregnancies are also at greater risk for loss or premature delivery due to abortion-related trauma and injury to the cervix. Finally, I'm going to describe a 3rd trimester-induced abortion, which is performed at 25 weeks to term. At this point, the baby is almost fully developed and viable, meaning he or she could survive outside the womb if the mother were to go into labor prematurely. Because the baby is so large and developed, this procedure takes 3 or 4 days to complete. On day 1, the abortionist uses a large needle to inject a drug called digoxin. Digoxin is generally used to treat heart problems, but a high enough dosage of digoxin will cause fatal cardiac arrest. The abortionist inserts the needle with the digoxin through the woman's abdomen or through her vagina and into the baby, targeting either the head, torso, or heart. The baby will feel it. Babies at this stage feel pain. When the needle pierces the baby's body and the digoxin takes effect, the life of the baby will end. The abortionist then inserts multiple sticks of seaweed called laminaria into the woman's cervix. They will slowly open up the cervix for delivery of a stillborn baby. While the woman waits for the laminaria to dilate her cervix, she carries her dead baby inside of her for 2 to 3 days. On day 2, the abortionist replaces the laminaria and may perform a second ultrasound to ensure the baby is dead. If the child is still alive, he administers another lethal dose of digoxin. The woman then goes back to where she is staying while her cervix continues to dilate. If she goes into labor and is unable to make it to the clinic in time, she will give birth at home or in a hotel. In this case, she may be advised to deliver her baby into a bathroom toilet. The abortionist then comes to remove the baby and clean up. If she can make it to the clinic, she will do so during her severest contractions and deliver her dead son or daughter. If the baby does not come out whole, then the procedure becomes a D&E, a dilation and evacuation, and the abortionist uses clamps and forceps to dismember the baby, piece by piece. Once the placenta and all the body parts have been removed, the abortion is complete. Late-term abortions have a high risk of hemorrhage, lacerations, and uterine perforations, as well as a risk of maternal death. Future pregnancies are also at a greater risk for loss or premature delivery due to abortion-related trauma and injury to the cervix. As I mentioned at the beginning, I'm Dr. Anthony Levatino, and in the early part of my career as an OBGYN, I performed over 1,200 abortions. One day, after completing one of those abortions, I looked at the remains of a preborn child whose life I had ended, and all I could see was someone's son or daughter. I came to realize that killing a baby at any stage of pregnancy for any reason is wrong. I want you to know today, no matter where you're at or what you've done, you can change. Make a decision today to protect the preborn. Thank you for your time.
I will no longer do any more abortions. When you finally figure out that killing a baby that big for money is wrong, that it doesn't take you too long to figure out it doesn't matter if the baby is this big or this big or this big or maybe even this big, it's all the same. And I haven't done any since then, and I never will.
That was abortions. Now the question we all ask is, what if the mother's life is genuinely threatened? There is a significant difference between abortion on the one hand and legitimate therapeutic medical treatment to save a mother's life on the other. Abortion is the intentional and willed destruction of a preborn baby at any stage of development after fertilization. In contrast, there is legitimate, essential medical treatment a pregnant mother may choose to save her life. This includes the action of delivering the baby prematurely, which may cause the baby's death. But such therapeutic action is never done with the direct purpose or act of killing the preborn baby. Operations that are performed to save the life of the mother, such as the removal of a cancerous uterus or the treatment of high blood pressure or an ectopic pregnancy that poses the threat of imminent death, and where this treatment results in the death of the baby, are not considered abortions and as such are not immoral. This is not to be confused with the often used term therapeutic abortion, which is a misnomer, since ending the life of a child is not a therapeutic act and is never in itself necessary and sufficient to save the mother's life. When conditions such as these are diagnosed, doctors will monitor and manage the case as best as possible to ensure a successful pregnancy. But if the condition worsens to a degree that threatens life, then the doctor will simply deliver the baby early to save the mother's life. If they have the technology to save the baby outside the womb, they would do so. And this has been done with emergency C-section plus incubation. This is terminating the pregnancy, but again, without the intent or direct purpose of killing the baby. Looking at ectopic pregnancy, this is where the fetus develops outside the uterus, typically in a fallopian tube. The fetus cannot survive outside the uterus, and if it is left to grow, it may damage nearby organs and cause life-threatening loss of blood. The intention is to save the life of the mother by removing the unborn from the fallopian tube, where it would inevitably cause death to both mother and baby. In the case of removing an ectopic pregnancy, the death is an accidental secondary effect and not an intended consequence of the act to save the mother. So this medical treatment, even if it is fatal to the baby, is not a procured abortion. The doctor wants to save the baby but knows that it is perhaps unlikely. Knowledge of consequences that will result from committing an action is not the same as intending the consequence. So bottom line, abortion is not needed to treat an ectopic pregnancy, and the current treatments that are available for such pregnancies are not even considered abortion at all as far as the medical community is concerned. Professor John Bonar, former chairperson of the Institute of Obstetricians and Gynecologists in Ireland, has testified that the treatment for ectopic pregnancy is not abortion as far as the medical profession is concerned, but rather essential treatment to preserve the life of the mother. He further explains that a ban on abortion does not involve treatment of ectopic pregnancies. You would have to be a misguided doctor to think that it did. This is also confirmed by the All-American Life League, where they state, similarly, if conception results in an ectopic tubal pregnancy requiring diseased tissue in the fallopian tube to be removed, thereby necessitating the removal of the child with the tissue, the operation is not an abortion because there is no intent to commit one. The diseased tissue, not the baby, is the target of the doctor. The Dublin Declaration on Maternal Health Care 2012, that has been signed by over 1,000 medical professionals, carefully distinguishes between abortions and surgeries performed to save a mother's life. As experienced practitioners and researchers in obstetrics and gynecology, we affirm that direct abortion, the purposeful destruction of the unborn child, is not medically necessary to save the life of a woman. We uphold that there is a fundamental difference between abortion and necessary medical treatments that are carried out to save the life of the mother, even if such treatments result in the loss of life of her unborn child. We confirm that the prohibition of abortion does not affect in any way the availability of optimal care to pregnant women. The American Association of Pro-Life Obstetricians and Gynecologists also insist that medical procedures to save the mother's life are not abortions. Abortion is the purposeful killing of an unborn in the termination of a pregnancy. Our blog opposes abortion. When extreme medical emergencies that threaten the life of the mother arise, our blog believes in treatment to save the mother's life, including premature delivery, if that is indicated, obviously with the patient's informed consent. This is not abortion to save the mother's life. We are treating two patients, the mother and the baby, and every reasonable attempt to save the baby's life would also be part of our medical intervention. We acknowledge that in some such instances, the baby would be too premature to survive. Also look at this declaration created by the All-American Life League. In part, the statement reads, and that's the second paragraph, I agree that there is never a situation in the law or in the ethical practice of medicine where a preborn child's life need be intentionally destroyed by procured abortion for the purpose of saving the life of the mother. A physician must do everything possible to save the lives of both of his patients, mother and child. He must never intend the death of either. Former U.S. Surgeon General Dr. C. Everett Koop made the following bold statement. Protection of the life of the mother as an excuse for an abortion is a smokescreen. In my 36 years of pediatric surgery, I have never known of one instance where the child had to be aborted to save the mother's life. If, toward the end of the pregnancy, complications arise that threaten the mother's health, he will take the child by inducing labor or performing a cesarean section. His intention is still to save the life of both the mother and the baby. The baby will be premature and perhaps immature, depending on the length of gestation. Because it has suddenly been taken out of the protective womb, it may encounter threats to its survival. The baby is never willfully destroyed because the mother's life is in danger. This is confirmed by Dr. Levatino. He explains that in the 9 years he worked in New York as a professor on high-risk, late-term pregnancies, the solution was usually to induce childbirth or to perform a cesarean section to terminate the pregnancy. But the number of times he had to kill the baby through an abortion in those 9 years was 0. Please listen intently when Dr. Levantino addresses the woman's health loophole in this video by Live Action.
One of the biggest arguments of pro-abortion activists is that abortion is medically necessary. What's your position on that?
We hear all the time how abortion, including especially late-term abortion, is necessary to save women's lives. Nothing could be further from the truth. I spent 9 years working at a tertiary medical center. I mean, there are only certain hospitals in the country that are designated to take care of the really, really high-risk pregnancies. You don't want to duplicate the effort, it's expensive. So these hospitals get referrals from the surrounding area. And Albany Medical Center in Albany, New York, where I worked, was one of them. I was faculty at the hospital for 9 years. And I saw hundreds of cases of really severe pregnancy complications, cancers, heart disease, intractable diabetes out of control, toxemia of pregnancy out of control. And I saved, in those 9 years, I saved hundreds of women from life-threatening pregnancies. And I did that by delivering them, by ending their pregnancy by delivery, either induction of labor or cesarean section.
Delivering the baby.
Delivering the baby. And I always tell people, in all of those years, the number of babies that I was obligated to deliberately kill in the process was 0, none. And I'll give you an example. The key point about late-term abortion that so many people miss is that it takes days to prepare the cervix. This is not a natural situation by any stretch. If you're going to dilate a cervix sufficiently, that starts off essentially as a pinpoint, large enough to dismember or tear apart a baby this big, that cervix has to be dilated, and that can take anywhere from 24 to 72 hours. And especially when you're talking about later term pregnancies. Most life-threatening situations, the vast, vast majority of life-threatening situations in pregnancy are not going to arise until 24, 25, 26 weeks of pregnancy and higher. And when you're talking about that, you're talking about abortion procedures that take 2 and 3 days to prepare the cervix. And I'll give you a classic example. This is a real case. A lady came to the hospital at 27 weeks of pregnancy with severe toxemia. Her blood pressure, you know, a normal blood pressure is about 120 over 80. Her blood pressure was 220 over 160. Okay, this lady would literally be minutes or hours away from a stroke. What do you do in a situation like that? We stabilized her, brought her back, did a cesarean section, had her delivered within an hour of arriving at the hospital. She and her baby did just fine.
Amazing.
Now, let's say we wanted to use abortion to save her life, okay? If with that kind of blood pressure and that kind of problem, if we waited 2 to 3 days to get her cervix prepared, she would never make it. She would have been dead. And that's a perfect example. You never need late-term abortion to save a woman's life. If necessary, you accomplish the delivery. Now, did every one of those children make it because they were preterm? No. But they all had a chance, and most of them did make it.
What you're saying is so amazing, Dr. Levatino, because a lot of people never hear this. They assume when abortion is brought up that it's necessary to kill that child, sometimes to save the mother's life. But you're saying it may be necessary to deliver the baby, but you never have to purposely go and kill that child.
That's exactly what I'm saying.
So why is this such a huge argument for pro-abortion advocates to say it's necessary to kill to save the life of the mother?
That argument I don't understand. In my experience over almost a decade, I never had to kill deliberately a single child to save a woman's life during pregnancy. There's a wider discussion, though. Politically, always listen very carefully to the words that are being used. You know, we need to pass law X, Y, and Z because it protects women's health. Bill Clinton, I will be happy to sign a ban on partial birth abortion so long as it includes an exception on women's health. Well, what do they mean? Now, I have a law degree, and every lawyer knows that every single word has meaning. And what Roe didn't do was define the word health. Doe versus Bolton did. It says that health, the term health, includes a woman's physical health. Okay, but it didn't say how badly impaired her physical health had to be for it to be a problem. It includes her mental health. Okay, but again, how bad does her mental health has to be? I suppose I can imagine, I never saw one, but I can imagine a case of if the woman's going to have a psychotic break because of her pregnancy, that certainly seems like a severe mental health problem. How about she's under tremendous stress? How about, I just don't think I can cope with this pregnancy? That's mental health too. It includes her economic health. Whoa, how much money do you have to be economically healthy? Not defined. And if that wasn't enough, it includes her social health. What in blazes does that mean? What it means then when a politician says, I would be happy to support your bill so long as it has a health exception, translation, I would be happy to support your bill so long as it contains an exception so big that the bill is of no real practical effect. I can't understand why any woman would want to have a medical abortion, and I'll explain why. No matter how abortion-minded she is, there are a lot of problems with RU46.